So it's my pleasure today to introduce your speaker. It's Carmel Gregan-Ford. And Carmel trained as a nurse in South Canterbury and completed her renal training in the UK, where she worked for 6 years. She has held a range of roles, including clinical nurse educator and consultant for the Strategic Renal Service Review and pre-dialysis educator with the Auckland DHB. Carmel was National Education Manager for Kidney Health New Zealand, where she worked for more than 17 years, developing education resources for the management of chronic kidney disease. She currently works for the Cancer Society of New Zealand. And Carmel's topic today is chronic kidney disease. Welcome, Carmel, and thank you for presenting today.
Thank you, Pauline, and hello, everybody. This is the first webinar I've given for a long time, so bear with me. Nice to have you all here. So I'm talking about detection and managing chronic kidney disease in primary care mainly, an area which is something probably needs a bit of improvement we've discovered over the years. So hopefully at the end of this you'll know what the risk factors are for CKD. I'll call it CKD, it's less of a mouthful, and how to identify it, how to detect and stage it, and what the management of it will be. Okay, so just a little bit of revision really for all of you, I'm sure, about the functions of the kidney. Obviously we have two, and actually most of us have two, some don't, but they're usually about the size of your fist, and they sit in your lower back. So they do a number of things, and I think people underestimate the role of the kidney. Actually, they do a lot of stuff that people are unaware of, and I'll run through some of them and highlight some of the ones I think are of probably greater interest. So first of all, they eliminate waste, and we know that that's their main job. They also balance our fluid and electrolyte system. They regulate our blood pressure. Most of you will be familiar with the angiotensin-renin mechanism, and I'll talk about how we manage blood pressure and kidney disease and how important that is a bit later on. And one of the other things they do, which I think is really useful and people often don't know, is they regulate the red blood cell production in the body. So what happens is there's a hormone that the kidneys release called erythropoietin, and erythropoietin stimulates the production of the bone marrow just to produce red blood cells, and they go around the body. Obviously, when that doesn't happen, that's when you'll see some of the symptoms of kidney disease, and when it manifests itself in such conditions like anemia, and people get tired and all those other things that come with anemia. And of course, with the wonderful introduction of the synthetic form of erythropoietin, it's kind of what I would call the wonder drug. That was probably, when I was living in the UK, it was quite new. So that came out in the 1980s. That changed the face of management of kidney disease quite significantly, to the point where people didn't require blood transfusions anymore, and that was a huge thing, because two reasons why we don't like to give blood transfusions for people who've got kidney failure, particularly if they're going to go on the transplant list, is one, that by giving them blood transfusions, that can increase their number of antibodies in the system, so therefore it makes it much harder to match a donor kidney for them. And the other reason, which of course isn't so significant now because all blood is screened, but prior to that, in the days when I was in the UK, the blood wasn't being screened that had been donated, and people were getting HIV through blood transfusions, so that was a real issue. So then came along erythropoietin, which was, again, as I say, a wonder drug. It helped increase people's hemoglobin. We would not normally let people's hemoglobin go above 110 to 120 at the most if they were on erythropoietin, because of the risk of possible clotting, which was one of the side effects of erythropoietin, the synthetic form. And of course, the other thing, which I think is quite interesting, is erythropoietin. You'll be familiar with the Tour de France, and over the years, people have been, or Lance Armstrong, for instance, was a great example. He used that drug as to help him with his iron carrying capacity, oxygen carrying capacity in his blood. And of course, he got caught doing that when they finally got a test in that could actually test for it. But when it first came out, there was an article in the paper where there were about 6 Italian cyclists who had been were cycling, and they were fit, healthy young men, but over the course of about 6 or 8 months, they all died for different reasons. And when they actually went back to find out, they actually found out they'd been taking erythropoietin on top of what was a normal hemoglobin, so it was increasing the viscosity of the blood, and they were having blood clots and dying. So it's got a bit of a dodgy history as well, but it certainly is a wonder drug, and it's still used a lot in dialysis patients, particularly today. And the other thing that I think is really interesting is the regulation of bone metabolism that the kidneys do as well. And what the kidneys do is they recognise, they turn the form of vitamin D from its inactive form, which we get from the sun, to its active form of vitamin D. And vitamin D is really important for the control and absorption and transportation of calcium around the body. And when vitamin D is not being activated because the kidneys aren't working, one of the side effects is they get this thing called hungry bone disease. The calcium levels become low in the blood. So what happens is and here's another complication, the parathyroid glands, which are the four glands that sit around sort of either side of your esophagus, if you like, they release a hormone called parathormone. And what parathormone does is it stimulates the production of this hormone to go around the body and make sure that calcium is delivered to the right places. But sometimes what happens is the parathormones become overactive. So they're taking too much calcium away, and they take calcium from the bone, particularly the long bone, and then they transport it back into the bloodstream where it's needed for the elasticity and the clotting form, which is required in the bloodstream, which is what calcium is also used for. So when that happens, our patients get this thing, as I said, called hungry bone disease. And the way we test for that is when people come into your clinic and their kidney function might be, very low. I'm going to talk about the staging, but say it gets down to stage 2, then we do check their a hand X-ray. And what that shows us is whether or not there's been any evidence of bone degeneration or hungry bone disease, as we call it. And it looks like when it has happened, a mouse has come and nibbled around your fingers. It's easier to see on an X-ray of a hand than it is to see on a large bone like the femur. So that's what we use. So to treat that, we have to try and slow down the rate that stop what the parathyroids are doing by delivering this parathormone around the body. So often you'll see patients with part of their diagnosis will be chronic kidney disease with secondary hyperparathyroidism. And what that means, that the hyperparathyroidism is secondary to their kidney disease. So what happens is then we remove the parathyroids. Usually we take, in the past, it may have changed since I was clinically working, but we would take the 4 parathyroids from the neck, and we would keep one and put it into either the sternum or just on the upper arm, just connect it up to wee blood supply. And sometimes just that one parathyroid gland would be releasing enough parathormone to regulate the calcium phosphate balance in the blood. But if it was still being hyperactive, then it could be removed quite easily rather than going back into the neck where we'd previously done the surgery, which is always quite dangerous. And to go back into that cavity is something we'd rather not do. So, so that's another thing that the kidneys do that you may or may not be aware of. So what happens to the kidneys in chronic kidney disease? Well, we've got in each kidney there's about 1 million nephrons. And who knows who sat down long enough to actually count them, but apparently that's what they say. So there's 100 nephrons in each kidney, and in each nephron there's a little thing called a glomerulus, and I'll talk about glomerulonephritis a bit later on, but that's where that comes from, and that's the filtering part of the kidney. So that does all the work. It does the absorption and transportation of the waste products around the kidney and decides what goes into the blood and what goes into the urine and what stays in the blood. So when those filters, if you like, stop working and they're damaged by whatever reason, and I'll talk about that in a minute, then that's when you get the kidney damage, what we call chronic kidney damage. And when we say chronic, because that means it happens over a long period of time. So the 3 main causes of kidney disease in New Zealand and in a lot of other places now as well, diabetes. As you can see there, 52% of our people who've got end-stage kidney disease is as a result of diabetes, and particularly type 2 diabetes. And often the damage that's caused by the kidneys isn't picked up with diabetes until much later, as often type 2 diabetes isn't picked up either. So it's kind of a double whammy. The next cause of kidney disease, most common cause, which is a wee bit down the track, is a nephritis, or what we call glomerulonephritis. And glomerulonephritis, or GN, because it's just a bit easier to say, there's numerous types of GNs, or glomerulonephritises, and that's when there's inflammation to the glomerula, the filtering part of the nephrons. And the causes of that can be all sorts of things, and most of the time we don't know what the cause of it is. It's just an inflammatory system that attacks the kidneys, and it happens to attack both, and we're not really sure why. Some have been linked to things like strep throat. Much like when you can get damage to your heart muscle from strep, you can also get damage to your kidneys as well. But there's all sorts of different nephritises, and they're usually identified by, when they look under someone's microscope, they'll see a crescent-shaped kidney cell, if you like, nephron, and they'll say they've got crescenteric glomerular nephritis. So that's kind of how they report it. There's one type of nephritis in particular, IgA nephropathy, which seems to be more common in younger people and Pacific Island people too for some reason. And that's the one that I think John Lomu may have had. And often that can manifest itself in the form of nephrotic syndrome as a symptom for a start, before they identify what type of nephritis it is. But IgA nephropathy can recur in the transplanted kidney. So if somebody's going to have a kidney transplant and the result of their kidney failure was IgA nephropathy, then the chances are they could get that back in their transplanted kidney further down the track. And patients are always told about that, obviously, prior to receiving a kidney, particularly if it's from a living donor. And the other one down there, which is another common cause of kidney failure, is hypertensive vascular disease. So basically high blood pressure over a long period of time. And that can be a cause or a consequence of kidney disease in actual fact. And some other causes which may be of interest, polycystic kidney disease. And I do notice the numbers of those have increased, and I think that's probably because people are a lot more aware, and there is quite a big organisation, particularly in Australia, of polycystic kidney disease foundation, if you like, and they do a lot of work and a lot of research around PKD. And basically, if you've got if one of your parents has got polycystic kidney disease, then you've got a 50% chance of getting it yourself. But the good news is, if your parents do and you actually go on and you don't, and you go on to have children, it doesn't skip a generation, so it stops about there. And polycystic means poly meaning many and cyst. So basically, the kidneys grow to accommodate the cysts, so they can be quite large. And we had a woman once, I remember looking after her, and she was a very tiny lady, and she ended up having a kidney removed for polycystic, because the kidneys get so big they can become really quite uncomfortable, and they can the cysts become infected and can be quite dangerous. So in this instance, this woman had her kidney removed, and it was 5 kilos. It was so big, and she was only about 55 kilos herself. She was tiny, so her tummy went down remarkably because it was quite swollen. And also, just a little aside, if you've got polycystic kidney disease, you've also got an increased risk of aneurysms as well. So, that's, yeah. So people often, we had patients in the UK when I worked over there, if they had polycystic kidneys, they'd automatically be scanned for aneurysms, and those aneurysms would often, if they were there, they would be clipped before they were allowed to go ahead and have a transplant. So, chronic kidney disease is a major problem in New Zealand, and it's not going away anytime soon. I just looked at some of the stats, which I'll talk about shortly, around kidney disease, and it's quite frightening, and we'll never be out of a job, that's for sure. We reckon that there's about 1 in 10 adults with some form of chronic kidney disease, and most of them won't know it. You've got to lose about 90% of your kidney function usually before you start getting any symptoms. And often with kidney disease, like many other diseases, it can be confused with something else, or just put down to tiredness, or that sort of thing. So so something that we're really mindful of. And it's also a major independent risk factor for cardiovascular disease. And the thing is, with that, it's common, it's harmful, and it's treatable. And that's the most important thing. And that's where primary care comes into being, and where, you can make a real difference with people's life, actually, where they can slow down the progression and they can live a pretty good life. So that's what this is all about. So hopefully you'll learn a bit about how we can do that. So what is chronic kidney disease? Well, as I mentioned before, it's when the tubules or the kidney's damaged, the structure and function of the kidney is damaged, and they aren't able to do their job. It's a general decline. And then what we do now, now with the advances of modern medicine, we stage it to make it much easier to sort out what sort of treatment we need to give. And I'm going to talk about what these are. So this is just a very brief one. I go further into it a bit further on. But basically it's staged based on the EGFR. And the EGFR, that little e, means estimated, because we are estimating it, glomerular filtration rate. So remember I talked about the glomerula, which are part of the nephron. So that's the filtration rate that the glomerulus are filtering the blood through the system of the kidney. If you think there's a million of them doing it at a time, it's a pretty busy system. So a normal GFR is anything above 90 mils per minute. So we kind of say usually a GFR of somebody with very normal functioning kidneys, probably in their 20s, would be anywhere between 100 to 120 mils per minute. So which is pretty good. So we start looking at when someone's got, or identifying or classifying chronic kidney disease is when their eGFR starts to slide. So you can see here on this slide that, I won't go into too much detail because I'll go into it a bit further, that we classify it right down to stage 5, and 5 is when they end up with established kidney failure and will require some form of dialysis or a transplant to actually keep them alive. So I'll go through what these mean very shortly. So the GFR, so how you define, when you say that someone's got chronic kidney disease, you do that as when someone's GFR is less than 60 mils per minute for 3 consecutive months, with or without evidence of kidney damage. So whether they've had some form of, trauma or something like that, or if there is evidence of kidney damage without the eGFR decreasing, so that can be with proteinuria, hematuria, pathological abnormalities, anatomical abnormalities. So that can be another reason you can call it. It can be defined as chronic kidney disease. So in New Zealand, this is what it looks like at the moment. Now, if you think we've got a population of just over 5 million, and at least more than 250,000 we think have got some form of chronic kidney disease. As you can see, it's a bit like it has been called a tsunami in the past. But our stage 5, we've got about 4.5, probably coming up to 5,000 people with stage 5 kidney disease in New Zealand. So that's somebody either who's on dialysis or has a kidney transplant. Now, when you get down to stage 4, a lot of those people, in stage 3, a lot of those people, so you've got, 90,000, nearly 500,000 with some form of chronic kidney disease in stage 3 and 4, then that's a lot of those you'll never ever see get to stage 5. Many of them will die from cardiovascular disease quite often, or other comorbidities. So to try and, it doesn't look quite as bad as it looks, but they don't get that far. But some of them are a lot older as well, and I'll talk about the ages that we've got for people with chronic kidney disease. So, and I apologise for the date on this slide, the 2014. I was trying to update it, but I couldn't do it for some reason. So I have got the new stats here. But basically, the renal replacement therapy in New Zealand has just gone up incredibly fast. When I first came back from the UK and I was working at Auckland DHB in their dialysis unit, we would have 5.5 shifts a week. So we'd do, 7 till 8. Monday to Friday, we'd do 7 till midday on a Saturday, and then we'd have Sunday off. So needless to say, it wasn't difficult getting staff in the dialysis units in those days because you didn't have to do night shift or work in the weekend much. So it was a pretty great place to work. But over the years, in the time that I was there, we went from having 1 dialysis unit to, I think with Auckland, there's probably about 4 or 5, including satellite dialysis units, and many of them work 7 days a week, 24 hours a day. So the demand has increased so much, exponentially in fact. And you'll see here that there's been an 83% increase in 14 years between 2000 to 2014. But if you see by this graph here, you'll see that it's just got over, say, 2,500, just over 2,500 on dialysis. There's now nearly 3,000 on some form of renal replacement therapy or dialysis. And as far as transplants go, it was just above 1,500. There's almost pretty much 2,000 people who have a kidney transplant currently. So it's a lot of people. So what's the goal? What are we trying to achieve? Well, we want to reduce the morbidity and mortality, and also slow down the progression of people ending up needing some form of dialysis. Dialysis is very expensive. To have hemodialysis, it's anywhere between, depending on whether you're on home dialysis or in centre in the hospital, it's anywhere between $60,000 to $80,000 per patient per year, which is very expensive. If you're on peritoneal dialysis, when you have dialysis through the bag system, that's slightly cheaper. It's about $50,000. If you have a kidney transplant, initially it's expensive, but it averages around $30,000 because once you've had a kidney transplant, generally speaking, people are much more well and can go back to work as well. So it's a double whammy there too. So we want to try and stop people needing any of those things, and we can. For a lot of patients, there are some that we won't be able to, but there are many that we actually can make a big difference to and slow down and prevent them from ending up with end-stage kidney disease. So let me tell you how. First of all, we've got to recognise that, in primary care, there's lots of inconsistencies around detection and management of CKD, and there's a lot of work needed to make lifestyle changes for some of these patients. So that is time consuming, and we all know how busy everybody is these days. And obviously, what we need to do, because we haven't got the resources to test every single person in New Zealand for kidney disease, but we need to really identify those high risk patients and get them treated, because they need a greater focus, and we can make a big difference with them. So what are the risk factors for kidney disease? So you've got somebody that comes into your clinic, and you look down the list here that we've got on the screen, and if they've got any of those, they're considered to be higher risk. And obviously the more they've got, the higher risk they are of getting some form of kidney disease. And as you can see, 1 in 3 New Zealand adults are at increased risk as a result. So these risk factors are very important. And you'll notice our Māori, Pacific and South Asian origin patients, very high risk. And I was just looking at some stats before, and for our Māori patients, the biggest cause of kidney disease or their kidney failure for them is diabetes, with 70% of Māori as a result of diabetes getting end-stage kidney disease. So that's a real issue. So if you've got somebody that walks into your clinic with diabetes, you need to check them for kidney disease as well, and I'll talk about how that'll work as well. If there's a family history of kidney disease, that's really important. When I went for Kidney Health, we used to do awareness raising campaigns, and we'd concentrate on one of these just about every year. And when we did the family history of kidney disease, we went to Northland, and we had a whole day, and we had lunch provided, and we invited those who were on dialysis, for them to invite their families in to have a test for kidney disease. And that was really successful, and we got lots of buy-in from that, which was great, because their family did not want to see, and also the people on dialysis did not want to become like them, and the people who are on dialysis did not want their family members to have to go through what they were going through. So that was a really powerful message, actually, so it was great. If you've got a history of acute kidney injury, that can also be a problem as well. And I had a guy once that we looked after when I was in the UK, and he came into us practically moribund. When we did some investigation to find out what the cause of his kidney failure was, we had to put him on dialysis. We realised his kidneys had failed, had no clue prior to that. But what happened was, when he was a young man, he'd been at a party and he'd fallen out of a window and ended up with a head injury. And while he was unconscious in intensive care, he was catheterised, and he was just eventually went home. He always had perhaps a lower intellectual function than he had before his accident. He lived at home with his mum. He was in his mid-40s, and he presented to us pretty much unconscious, and he had kidney disease, kidney failure at that stage, acute kidney failure, or acute kidney injury as they call it now. So on further investigation, it turned out that his urethra, so the tube going from his penis to his bladder, had stenosed. So over a period of time following being catheterised, so if any of you who catheterise men, be very careful, the trauma of the catheterisation had injured his urethra, and over the years it had gradually stenosed over the scar tissue, and so he was only passing very small amounts of urine. So the urine was backtracking up into his kidneys, into his ureters, and causing chronic infection and damage. That was while I was working in the hospital. He came back in had the surgery, and they did a urethroplasty where they slit his penis down the middle, actually, and let it heal for about 2 months. And he went home, and he was on dialysis for a period of time. Then they brought him back in, and they re-anastomised the penis together, and made sure that the tubing was working, if you like, and he was able to function. His kidney function returned, not to normal though, and I would suggest quite confidently that he would have ended up with end-stage kidney disease because of his previous injury. So that's something to be really mindful of, because that can, once the kidneys are damaged, that we can't reverse the damage that's been done to the kidneys. We can slow it down, but we can't reverse it once the damage is done. Another reason why it's really important to try and get onto it as soon as possible. So usually chronic kidney disease is identified by the tests that are arranged by a GP, and so generally speaking, your GFR does start to decline once you get over 50, I'm afraid to say. So it's usually an average of about 1 ml per minute per year, so that's okay. But if you've got significant kidney damage or issues, then it can reduce as much as 10 to 20 mils per minute per year, and that's when alarm bells should be ringing the first time that happens, at least. So how do we stage chronic kidney disease so we can decide on how we're going to treat it? Well, there's three different things that we do. First of all, we work out what the EGFR is, and I'll talk about that shortly. We'll stage that. What damage is done to the kidneys, and that's told. We can tell that by the amount of albuminuria or protein that's in the urine. And the clinical diagnosis, so what's the underlying cause. So if, for instance, somebody's diabetic, then obviously that would be the first thing we'd think about, but we'd certainly investigate other areas as well. Whether there is a stenosis somewhere in the kidneys and some sort of damage, then we would probably consider that too. So that's how we stage that. So this lovely picture is the staging, how we do it. And I'm going to do a case study after this, and you'll see how it's much easier how we use it. But essentially, you can see on the left hand, well, my left, probably your right, it's got G1, G2, G3. They call it grading, or it can be staging, so it doesn't matter. They both mean the same thing. So grade 1, as I mentioned before, is when you've got normal or high EGFR, high function. And then once it starts getting below 90, we start grading it or staging it, if you like. So the numbers here, the 60 to 89 or the 45 to 59, are actually the GFR, so the glomerular filtration rate, which we actually get from as an equation that we do with once we get the creatinine. So when we order the creatinine, the EGFR is automatically taken. So you can see that down that side, and then on the top you'll see persistent albuminuria categories, description and range, and there's A1, A2, A3, and that's the amount of albuminuria that we see in the urine test that we do. And these are quite significant. Needless to say, your anything greater than 30 milligrams per millimoles is severely increased albuminuria, and that would ring huge alarm bells for us. Again, in the old days, we used to go around shopping malls and things like that, doing kidney screening to raise awareness, and we would do albu sticks, which give us an indication. So kind of like the ones that you take when you're pregnant, and it measures the amount of albumin there. So the albu sticks are used as a guide, certainly not a diagnostic tool, but if they demonstrate there's like 3 or 4 pluses of albumin in the urine, that would ring alarm bells. And if they had a high blood pressure, we would send them off to their GP for a blood test to help clarify whether or not there's kidney damage there or not. So I'll talk about this, how this works a bit later on. So as I said before, the kidney health check, we do a blood test to check the EGFR, and that's calculated from the serum creatinine. We do an albumin or an ACR, albumin creatinine ratio, to check for albuminuria, and then we do a blood pressure, obviously. So as I said before, blood pressure can be a cause or a consequence of kidney disease, so that's a bit of an alarm bell raiser for us. But these tests really should be done with every chronic disease and cardiovascular assessment, risk assessment anyway. So, it's kind of a no-brainer. But unfortunately, kidney disease or chronic kidney disease is not on the list of chronic conditions, which is something we've tried very hard to change, but we haven't had any luck yet. So detecting your GFR, so it's the best measure that we use at this stage for measuring someone's kidney function. So for us, that's the best way. If we look at someone's EGFR, that gives us an idea of where their kidney function's at. So we estimate that from a serum creatinine using an equation, and there's all sorts of different equations that we use, and I'm not sure what the current one is, but there was the Cockcroft and Galt, which I think is old school now, and the MD-RD, I think they used to use too. So I'm not sure what they're using now, but whatever equation it is, it's all done in the labs, and they come back with when a creatinine's ordered with an EGFR as well. And interesting, as you can see on the slide here, it says that the creatinine the EGFR can fall quite substantially before the creatinine starts to. So that's why we like to use the EGFR as a better measurement, because it's a lot more accurate. So that's what and once it's below 60 for 3 consecutive months, then that tells us that would become as a diagnosis of chronic kidney disease. And detecting urine, urine tests and detecting CKD, well, we use the ACR, generally speaking, that's the most common one. And it's present in at least 2 out of 3 tests. If 2 out of 3 tests are positive, including the initial test, then that is considered to be CKD, and it's got to be persistent for 3 consecutive months. So it's now the preferred test rather than dipsticks. As I mentioned before, the sensitivity and specificity is not as accurate, so we definitely use the ACR. and we always like it to be the first test in the morning, if possible, the first collection. It's not a major if it's not, but that is a preferred way to test the ACR, is the first urine specimen in the morning. So the nurse's role in trying to sort of pick up if there's patients coming into your clinic who may have be at risk for CKD is, as I mentioned before, red flag if you've got somebody that comes in who's got diabetes, if they're hypertensive, if they've got cardiovascular disease or other CKD risk factors, which I mentioned before, such as your obesity, smoking, Māori, Pacific Island, Asian, they're all high risk. So they're the sorts of things that you need to think about when you're assessing one of your patients. To manage the disease, as I mentioned before, promoting self-management is really important. I know that can be hard, and I always say to people when they're having, when they're going on a diet or their blood pressure's high and they've got to reduce their salt, that if they're going to have salt, then they love their salt, then if they don't have it and don't add it to their meals, have it at the table and vice versa. So slow it down, just try and cut it down slowly rather than saying, no, you can't have something, because as sure as eggs, as soon as you're told you can't have something, all you can think about is it. So it's like going on a diet and giving up chocolate. All you can think about is, I really want a piece of chocolate, but I can't have it. So it's that kind of thing. So it's all that patient management stuff that I'm sure you're all fully aware of. Keep an eye on their progress. Make sure they, give them regular follow-up, particularly if they're on blood pressure medication, because you want to make sure that's working well and that they're taking it. That's always the big thing. And nephrotoxic medications, check what they're taking. And this is probably my biggest bugbear, and I'll talk about it more as we go on. But a lot of patients will be taking Voltaren or non-steroidals, and if they've got kidney disease, they shouldn't be taking them, because it can damage or increase the rate of kidney damage as well. So that's something to be really mindful of. In fact, years gone by, there's a really good database called ANZ Data, anzdata.org.au. If you're looking for data around any sort of kidney disease in New Zealand and or Australia, they're combined, but they are split. The results or the register that comes out, it actually comes out with Australia and New Zealand data quite separately. So it gives you a really good insight as to what the numbers are, the causes of kidney disease, the ages, the types of dialysis treatment, the number of deaths and so on. So it's actually a really useful tool. But in that is one of the headings of the common causes or causes of kidney disease is analgesic nephropathy. And a few years ago, particularly in Australia, it was noted that this was an increasing cause of chronic kidney disease, or end stage, in fact, and they discovered that people were taking Voltaren, and it was being prescribed sort of pretty, often and too often, and people were taking it for all sorts of things. I mean, it is a great drug, but if you have it too much and over a period of time there's nothing done to check up on it, it can cause quite bad kidney damage. So that's something I'm a bit hot on. So what blood pressure goals do we want to try and stick to? We've got somebody with chronic kidney disease. Well, as you can see below, these are the recommended guidelines from the Kadogi group, which is a kidney group in America, and they have got some really good guidelines around blood pressure management. And as you can see here, if you've got albuminuria in your urine, that's a real sort of, I suppose, a red flag for us. We really want to try and manage that, keep as tight blood pressure control as we possibly can if someone's got albuminuria. So we like to keep it below 130 on 80. And as you can see with diabetes and chronic kidney disease, we're a bit more lenient with 140 on 90. But certainly if they've got albuminuria, then we want to really try and tighten up that blood pressure control. And I'll talk about how we do that further just shortly. So here's our case study. This is a woman called Margaret, and she's a 56-year-old Māori lady. She's her BMI is 38. Her waist circumference is 120 centimetres. She's got type 2 diabetes. I mean, I won't read it to you. But interesting to note that her father had some kind of kidney problem a few years ago, and you hear this a lot. People say, "Oh, my father or mother or somebody, yeah, there was some kidney problem in the family, but I'm not sure what it was." And often it could have been something quite significant. So I guess some of the things that you'll notice here, she's a smoker. She has 3 glasses of wine 4 or 5 days a week. She doesn't really do much exercise. She does have high blood pressure, and she does take occasional non-steroidals. So some of those I'm sure will be red flags when you're hearing this. So I guess the first question is Margaret at increased risk of CKD, and why? And for those who are talking amongst themselves, yes, the answer is she is. And she's got several of those. She's got 6 of the 9 risk factors. She's diabetic. She's got high blood pressure. She hasn't yet got established cardiovascular disease, but my money would be she probably has got some early symptoms, particularly if she's got high blood pressure. She's of Māori descent, and she's overweight and smokes, and a family history, we think, of kidney failure. So, yeah, she's quite high risk, I would say. So how do they contribute to her likelihood of developing chronic kidney disease? Well, as I said before, with blood pressure, that can be a cause or a consequence of kidney disease. So the blood pressure can damage the small vessels in the kidney. So it's kind of like if you imagine a car battering a brick wall, just keeps going and going and going to eventually the wall collapses. And so that happens when you've got high blood pressure in the vessels of anything really, but mainly in this instance, the kidneys, that causes over time damage. And therefore they're not able to do their job, and they're not able to filter the waste products from the blood the way they should. So that's why you get this damage to the kidneys the way you do. Or if the kidneys are damaged, the blood pressure can go up because the vessels have been damaged, and so they have to push harder to get the blood through. So that's another reason. And obesity, of course, as we all know, so that's anybody with BMI over 30. And interestingly enough, that in transplantation, normally we don't transplant people, although I know some units have different protocols. But in the past, anybody who's got a BMI over 30 won't be able to have a kidney transplant. It's not considered a safe option. So then they'll have to go away and lose some weight before they can be accepted onto the transplant list. And as same goes for if you're going to be a kidney donor as well. Central obesity is more important than generalised obesity. So if you've got more of your weight carried around your tummy, and again, that's another risk factor with diabetes too, as I'm sure you'll know. And also the other interesting thing, that if you are overweight, you're more likely to develop albuminuria. And of course, it's much harder to control your diabetes or your blood sugar levels when you're overweight, and your blood pressure, of course. So that's always a key thing with trying to get people to help with their lifestyle modification. And another risk factor, of course, is smoking. And, of course, that's a risk factor for pretty much most things now. It's been associated with kidney damage, and those who are diabetics who smoke are also more likely to develop albuminuria, which basically means that smoking damages the kidneys vessels, as you can well imagine, with the vasoconstriction that goes on. So if you're a diabetic, you've got kidney disease and you smoke, then you're going to progress more quickly to end-stage kidney disease. So we're talking about the Māori ethnicity influence, and of course, unfortunately, in New Zealand, and in Australia, it's the same with the Aboriginal community. There's a higher incidence of chronic kidney disease in our Māori population, and that's mainly driven before, as I said, by the high rates of type 2 diabetes. And as I said, there's 70% of people of Māori with diabetes. 70% of Māori who've got end-stage kidney disease or on dialysis as a result of type 2 diabetes. And they're always disproportionately represented in any of our figures that we collect. So that's why it's really important to try and get them early, try and detect the kidney disease in these patients early, so we can actually make a difference, and we can. So there's a lot of work I know in some areas being done around trying to engage Māori and Pacific people to come in and get checked early. And I think the trick to that is getting out into the communities, which, is always expensive but worthwhile in the long term. If you think about the cost of kidney disease in New Zealand, and I don't have the exact figures, but it's phenomenal. And the cost of preventing is a lot cheaper. So diabetes, well, that's a long-term complication, obviously, and usually if you've got type 1 diabetes or type 2 rather, it manifests itself in 5 to 15 years of diabetes. You're going to have some form of kidney damage. So therefore, if someone's diagnosed with diabetes, you need to start looking after their kidneys straight away. So as I say, at least half the people, if we're talking in general, the New Zealand population will have diabetic kidney disease. And we tend to look at the albuminuria because often the EGFR is quite normal. So we'd like to test diabetics, do an ACR on diabetics often. And I think that's a really important practice to maintain. So she has 6 of the 9 risks for CKD. So what do we do now? Here we go. So here we go back to our earlier slide where we a blood test, a urine test for albuminuria, and a blood pressure check. And they're obviously really important. Very easy, apart from the blood test, reasonably non-invasive. And we do Margaret's health check, and it's telling us that her GFR is 90, which is good. Oh, no, it's not. Sorry, that's normal ranges down below. It's telling us it's 55 mils, so she's got, half of her kidney function's not, or just over half. Her ACR result is slightly high, and you can see the normal results below. And her blood pressure is high as well. It's 155 and 95. So, and as you remember before, if you've got albuminuria, which she has, we should really be keeping her blood pressure less than 130 on 80. So, what are your initial thoughts about Margaret's risk for CKD? Well, I'm sure you're all thinking she's got pretty high risk. And what do her results mean? So what you would do, if this was somebody that comes into your clinic, they're diabetic, they're hypertensive, you would then start your checks for your CKD. So you would do an ACR, you would do a blood test for creatinine, and the EGFR is done with that, and then you would repeat that within 3 months. You would then also, prior to the results coming back, you'd also start talking about some lifestyle modification, because you really want her to start making some changes to help with that, and smoking, perhaps lowering her alcohol intake, and increasing her exercise would be a start, and perhaps talking about some of the things she could do nutrition-wise. And then she goes back to the GP in 3 months' time, and you'll see her results below. Her first visit, her initial one we saw earlier, then 2 weeks later, and you'll see that her blood pressure has started to come down slightly, but so has her EGFR, which isn't good. Also, just on that note, the creatinine will go up and the GFR will come down in kidney disease. So it's an opposite effect. So when someone's creatinine starts to rise, so anything over sort of 90 to 100 mils per minute for creatinine, and then when it starts to go down for the EGFR, so it's an opposite effect. And so you'll see that 3 months later, Margaret's GFR has come up a little bit, but her ACR has got worse, and her blood pressure's got worse. So I'm not sure why that is. So what do we do about that? So if you remember that I might have to go back actually the other slide. So if you remember that her ACR was 8.4 and her EGFR was 52. So you put an EGFR onto the table there. 50, what did I say it was? 52. So you would, I'll put a wee star up to show you where it is. You'll have a look at the table there, and her albumin would come under going back to 8.4, so she would come under the A2. So therefore, she would be stage 3A. So hopefully you can see how that works. So it's basically going along and down. So to say she's, if you look at the risk of CKD progression below, she's high risk. So that's a really good way to actually get you at least a bit of an idea as to what to do from here, or where she's at, and what you can do to try and slow down the progression of her kidney disease. Or damage, really. So this is, it's a bit blurred actually, but this is the CKD Management General Practice Guidebook, which I've got down here. It's 2013. We actually do have a 2017 summary guide. So, and that is that's the most up-to-date one, but this is a good guide for helping manage your CKD patients. And you'll see on one of the pages, this is what it shows. So in this particular instance, where you've got Margaret with her CKD being stage 3. So on the right-hand or left-hand side, probably for you, it says you've got to monitor her GFR 3 monthly, avoid nephrotoxic drugs, and I can't stress that enough. So I had a woman ring me up one day, and she was CKD3, so her GFR was 40. She was only 42, I think, herself, and she was being prescribed. Her GFR was 40, and she was being prescribed Voltaren for her arthritis. So I suggested it might be wise for her to go back to a GP and ask if she could change the type of painkiller she was on, because that wasn't good for her kidneys. But I couldn't do that. I couldn't tell her not to take it, but I certainly strongly advised her to go back to a GP. Then with her blood pressure, obviously we really want to try and get her blood pressure under control, because remember, she's albuminuric, and and she's diabetic, so she's really high risk of developing her CKD getting worse reasonably quickly. So what we tend to do is we prescribe anti-proteinuric drugs. So that's your ACE inhibitors. So that's your or your ARBs, so your cilazapril, your enalapril, those sorts of things. And they are, as I say, anti-proteinuric drugs. They reduce the amount of albumin being lost and hopefully retained within the kidneys. So they work that way. They help slow down the progression of kidney disease, we think, or the kidney damage to a certain degree. And there is a new wonder drug, and I can't for the life of me think of the name of it, that has come out more recently that can be used particularly for diabetics. And I apologise for that, because I should know it, but I think it's ganacaflosin actually, and that has been found to be really effective in diabetic kidney disease. So ganacaflosin. So Google that, because it's actually a new drug coming hopefully into the New Zealand market very soon. Make sure the drug doses that they're having is appropriate for the level of kidney function, because when someone's kidney function starts to decline, then obviously the ability to filter some of those drugs through the nephrons aren't as good, so there can be a build-up and you can get toxicity. So be very mindful of that. And then have a look and see whether or not you need to get them, refer them on to a nephrologist. And at this stage, I would probably think it's unlikely. So how's Margaret's cardiovascular risk determined? Well, it's one of the biggest, CKD is one of the most potent known risk factors for cardiovascular disease. So it's really important that we can stop that from happening. So anybody with chronic kidney disease got a 2 to 3-fold greater risk of cardiac event or death. So people with CKD are at least 20 times more likely to die from cardiovascular disease and survive to need dialysis or transplantation. And I think I showed you that model at the very beginning of the talk, the sort of the pyramid type thing that sort of showed the big mass gathering of the CKD 2s and 3s, and where they are more likely to be not make it to dialysis or transplant because of the cardiovascular risk. So they should be routine, as I say. So how can we help reduce her risk and other people's risks? Well, this is the nutrition thing I talked about, or SNAP, which is it's actually an Australian anagram, but it's quite easy: smoking, nutrition, alcohol, and physical activity. So basically all the things that we know, an exercise program, try and low calorie, reducing alcohol intake, low salt diet, and to stop smoking where possible. So they're the key things, and that'll help with your blood pressure control. And this is really important too, I think, when I talked about the anti-proteinurics, these are the preferred drugs, the ACEs and the ARBs, and other antihypertensives can be brought in to help improve the disease, but it's important that you can actually use up to 3 to 4 different medications, and often they're required for people who've got hypertension that's very difficult to manage. And if it gets beyond that, then you'll need to probably refer on to a nephrologist. Now, you'll notice down at the bottom the clinical tip: avoid the combination of ACE and ARBs. Don't prescribe them together. They should be either one or the other, not together. It's proved that does lead to other issues. Now my back pain thing, the non-steroidals, it's actually not, I need to change this slide actually, because I was showing this to a nephrologist one day. He said actually it has proven to not cause CKD, but certainly cause further damage to the kidneys. They aggravate, as it says there, the underlying kidney disease, and they increase the risk of vascular events. So it's something to be really mindful of, to avoid non-steroidals where you possibly can. Now, do we need to refer Margaret to a nephrologist? Reminder, she's got stage 3 microalbuminuria, and she's got a history of hypertension. She's a smoker and she's overweight. Her latest results, her EGFR stayed stable. Her ACR's sort of the same, but her blood pressure is still a problem. But her cardiovascular risk assessment is 13%. So, it's not low, but it'll get higher as her kidney function deteriorates. So no, we probably don't need to refer her. This can be all done in primary care. So, and you can use the guide, the EGFR guide that we have. Usually if her GFR is stable and greater than 30 mils per minute, we don't worry about them seeing a nephrologist at that stage. That can be managed perfectly well in primary care. If their ACR is less than 30, again, we can, and there's no hematuria, which obviously is always a risk factor of something else going on. And if the blood pressure is under control, then that's okay. But if it's not able to be controlled with the 3 or 4 blood pressure medications that she's on, then that will mean she'll probably need to be referred to a nephrologist. But in the meantime, most of it can be done in primary care. Again, as you can see below the footnote, if there's younger people, then the indications for referral may be a little bit different. So be guided by that. But there's all sorts of tools now we can actually work out what their staging is, and most nephrologists are reasonably friendly. In fact, they all are, to ask if you've got any questions. You can ring them up and they'll tell you whether or not they're up for a referral or not. So this is when we refer patients when the eGFR is less than 30. If they've got significant albuminuria, so greater than 30 milligrams, and a sustained decrease, as I mentioned before, 15 mils within 12 months. So if their GFR is dropping really fast, then that's certainly a red flag. And if you can't get their hypertension under control, and if they've got diabetes, of course, then they can be referred earlier because they're more at risk and may need other management. So if it's less than 45 mils per minute, then you can refer. So what's next for Margaret? I'll work through these. I see what the time is. I'd start her on ACE inhibitor. Obviously encourage her with the smoking to stop doing that. Make sure her blood pressure's still below target levels. Decrease her alcohol consumption if she can. Consider green prescription and a dietitian to help her if she's having issues with that. Avoid nephrotoxic drugs, and make sure she's on your recall list to follow up in 3 months' time. That's really important, to make sure she is followed up to see if all these measures are actually working. And we've got people going to the community doing this now too. So here's what her targets are for her. We want her to have, because she's got albuminuria, it needs to be 130 on 80 of blood pressure, so tight modification there. Her cholesterol is often an issue, and HbA1c we need to keep an eye on too, and so she can have oral hypoglycemics or even insulin if needed. So, in summary, chronic kidney disease is common, harmful and treatable, as I said before. Early detection is really crucial, and I can't stress that enough. If you've got people with those risk factors coming in through your clinic, then you need to really start thinking what you can do to test and and start staging them so you can start planning their treatment. The high risks, the risk factors, and what we need to do to test them. We need to really keep that blood pressure tightly controlled. That's really important. And always check the ACR. Albumin is a really important indicator for the progression of the kidney disease. Refer to the staging tables, and they can be found on the website or in those books, which you can get from Kidney Health. And pretty much most CKD patients can be managed in general practice, because you guys know what you're doing. It's just picking them up at the right time and detecting them and managing them, and you've got a vital role to play in that. So, so we've got a potential to halve the numbers of people presenting with kidney failure, which is pretty cool. And then just some of the resources that you can find. There's all sorts of resources that are out there. And some of this module was designed originally by Kidney Health Australia, but I borrowed it and modernised it for the New Zealand setting, along with some other wonderful colleagues. So, and that's just some of the references. Thank you. I hope that was helpful.
Thank you, Carmel. That was a lot of information, really, really useful. And I can see by Googling, you can get all those charts that you've used. They're on the Ministry of Health website. So I've just left a message about that on the chat function to help people Google correctly and get to that quickly, because I think those will be really useful. A couple of questions. What are the alternatives to Voltaren for patients with rheumatoid arthritis needing to take anti-inflammatories?
Yeah, I must admit, I'm not very good on the alternatives, but there are things I have heard. There's one, it's completely stopped my mind, that people use, and some people like it, some don't. No, it's gone. But just you'll need to, the nephrologist will know, yeah.
And what is the significance of creatinine clearance, and when should one use this instead of EGFR? Generally speaking, with creatinine clearance, that's when you order a creatinine, the EGFR is automatically calculated from that. So therefore, you don't really need to use the creatinine clearance. It's useful for some things, but as far as identifying and diagnosing kidney disease and the progression, then the EGFR is the best way to go.
see. I mean, I can talk a bit about transplantation if you like, just really quickly. I mean, people who are on dialysis, they can, we have, as I say, we've got probably 3,000 people almost on dialysis, but only a quarter of those will ever go ahead and will be put on the list for a kidney transplant, again, because of their cardiovascular disease or other comorbidities. So, and the average rate of transplantation in New Zealand's gone from about 120 a year to about 180 in the last couple of years, which is fantastic. So we've got some good increased rates of transplantation, and the outcomes of those are very positive. We've got, some people that live between 20 and 40 years with a successfully functioning kidney transplant.
That's really positive too. 2 more questions have come in. So is BMI appropriate, Carmel?
BMI, I wonder what she means by that. BMI for measurement of
weight.
So we have used BMI as our guide for. Actually, I suppose they're probably relating to Pacific and Maori people. Yes, no, and there are other ways of measuring it because the BMI in those can be a bit with Maori and Pacific people can be inaccurate. So there are other ways that the nephrologists use that as a measure rather than BMI.
Right. Yeah. And another question, how does kidney damage actually cause hypertension? That's a problem.
How does kidney damage cause hypertension?
Yes.
When the kidney, if hypertension hasn't caused kidney damage, then often like in diabetes, for instance, you've got the damage to the blood vessels. So therefore, the blood vessels in the heart and in the kidneys are narrower. So therefore, the pressure of getting the blood around increases. So therefore, the blood pressure goes up because of the damage. There's less vascular area, if you like.
Oh. We've done really well, and there's no more questions. So I think it just remains for me to thank you again and thank everybody who attended today.
Thank you.